Okay, so we will take NEET-PG PYQs of anatomy in today's session, and starting with very first question, which it was about the action of the muscle, which is shown by the number, and what action they do actually at the metacarpophalangeal joint, right? Thank you, Shanawaz bhai. Thank you. Right. So, firstly, you have to identify the muscle, right? And secondly, you have to mention the action at MCP joint, right? So if you look here in the image, you can see there are 4 muscles. Like, the numbering has been done from lateral to medial, right? So this is the order of numbering from lateral to medial, because first, second, third and fourth. Now if you look properly, can you identify which muscle is this? Let me see if someone can answer this. Can anyone tell me which muscle is shown in the image? Which muscle is this? Anyone? I have just given you a hint. There are 4 muscles and we are counting from lateral to medial. And let me see if anyone can identify the muscles. Else I will give you further more hints that will make your work easier. Okay, now look here. You can see the long tendons. Okay, so these are the tendons of flexor digitorum profundus. Okay, so this is flexor digitorum profundus. Now can anyone answer? Because there are some intrinsic muscles of the hand which arises from the flexor digitorum profundus. Anyone? Okay, Sneh, that is one thing. Yes, you are right. Unipennate, bipennate, that's okay. But I just want to know whether you can identify the whether you can name the muscle or not. So I just want to see whether you can identify the muscle or not. Right? So anyone? I just want to know the name of the muscle. And I have given you a hint that these muscles are originating from flexor digitorum profundus. Now these muscles are actually the lumbricals. Okay, so these are the lumbricals, and which are 4 in number. And okay, Sneh, yes, those are the small muscles of the hand. But these 4 muscles, like 1 and 2 and 3 and 4. So these are the lumbrical muscles which originate from the tendon of flexor digitorum profundus. Clear? So that is one thing. Yes, Shanawaz bhai, absolutely right. So this is one thing. Now second thing is that these lumbricals, all of the 4 lumbrical muscles don't have the same nerve supply. So first and second are supplied by median nerve, okay, and third and fourth is supplied by ulnar nerve, right? So just remember this thing. This is very important, and this is the same as what we see in case of flexor digitorum profundus, because the medial half of the flexor digitorum profundus is supplied by ulnar nerve, and the lateral half of flexor digitorum profundus is supplied by median nerve. So same is the case with lumbricals. Now coming to the second part of the question, like what is the action of lumbricals at metacarpophalangeal joint? Very good, Sneh, very good. Right, so what they do actually, they flex MCP and they extend at interphalangeal joint, right? So somewhat this kind of posture. This is the action of lumbricals. Very good, Sneha, very good. So this is the thing. And as Sneha pointed out, if there is paralysis, so if we can just add here, paralysis of lumbricals, what will happen? The reverse will happen. So extension at MCP and flexion at IP. So what it will become? It will become like this. So this is known as clawing, right? So this is known as, this attitude is known as clawing, right? And therefore when we discuss the ulnar clawing, we see that there is only involvement of third and fourth lumbricals, involving only the ring finger and the little finger. If there is median of involvement, there will be involvement of the index finger and the middle finger. And if both the nerves, median and plus ulnar, is involved, then only we will have the total clawing, right? So that's why total clawing involves both the nerves. So that is very important. And why it involves both the nerve? Because of this uniqueness of the nerve supply of lumbricals. All the four lumbricals are not supplied by the same nerve. First and second by the median nerve, and third and fourth by the ulnar nerve, right? So these are the lumbricals, and the action of lumbricals at MCP joint is flexion. Okay, so please remember. Okay, so these are lumbricals. Now, next question: which of the following structure does not pass through the aortic opening? Now this we have already discussed in our FMG PYQ sessions, but again I've just kept this question and I think all of you can answer this. So which of the following structure does not pass through the aortic opening of diaphragm? And yes, Sneha, you are absolutely right. The answer is phrenic nerve. Okay. So apart from this, aorta, thoracic duct and a gyrus vein. The mnemonic, I think most of you must be knowing, is ARTA, right? So that is for aortic hiatus, right? So that is for aortic hiatus. Shana was absolutely right. Phrenic nerve does not pass through the aortic opening. And just to show you what is aortic opening, so if you can look here, this is the right crus of the diaphragm, this is the left crus of the diaphragm, right? So this is the right, and this is the left crus, and this is the right crus, and in between the two there is a osteoapneurotic defect. So this is actually a osteoapneurotic defect through which passes the aorta, right? So from here, this is the aorta here, right? Now this aortic opening is not a true opening. I have just discussed this before. So aortic hiatus, some unique facts which you should know about aortic hiatus: it is an osteoapneurotic defect, right? It is not a true opening because its lumen remain unchanged, right? So the lumen or the size remains unchanged irrespective of the fact whether the diaphragm is contracting or relaxing, right? So it has nothing to do with Shanawaz. I upload the PDF of all these sessions on my app, right? So you will get the PDFs on my app, right? So don't worry for that. I'll give you the link for the app as well, right? So it's not a true opening, and therefore the size remains fixed. And this is very important to understand, because suppose if it is passing through the muscular portion, the diaphragm will contract and that will compress the aorta. Therefore there might be possibility that the lower part of the body might get less blood supply, right? So just to make sure that the amount of blood supply which is going to the abdomen or the lower limb is not influenced whether the diaphragm is contracting or relaxing, it is through a opening which is not a true opening. It means the lumen size is fixed, because we know that diaphragm is a muscle, so it contracts as the relax. So it's other openings, the size might vary, but not for this, right? And the structures which pass from here: aorta, thoracic duct and a gyrus vein. Just remember these three, and the answer therefore is the phrenic nerve, which does not pass through the aortic opening. Okay, so please remember this much. Now next question is about tensor of vocal cord. And yes, Sneha, absolutely right. You are perfectly right. So this is cricothyroid, right? So now, in case of laryngeal muscles, it is very easy to identify the point of origin and insertion because they are mentioned in the name itself. So suppose if I am telling you like cricothyroid, so it means it is one attachment is over the cricoid cartilage, and obviously the second is at the thyroid cartilage, right? So very easy to identify cricothyroid, because if you look here, this is thyroid, okay? So this is the thyroid and this is the cricoid, right? So this is cricoid. So there is a muscle which is extending from the cricoid to the thyroid cartilage. So if you look here, this is the muscle which is extending from the cricoid to the thyroid, and therefore this muscle is cricothyroid, and it has got two parts, and when it contracts, it tenses the vocal cord, it stretches the vocal cord. Sneh, see, there is one Morgagni hernia, okay? So there can be Morgagni hernia, right? So if you look here, Morgagni hernia, you might have question, many times you have question on Morgagni hernia, and which is on the commoner on the left side, right? So Morgagni hernia can be a point of herniation, yes. Okay, so many times we discuss Morgagni hernia, clear? So okay, so that is something what you have asked. Chalo. Right, so tensor I think is okay, and you can see here there are the two parts of this muscle, right? So cricothyroid, extending from the cricoid till the thyroid cartilage. One thing is that it is a tensor of vocal cord, but apart from that, you should also know one more thing, that all muscles of the larynx are supplied by recurrent laryngeal nerve, right? So all are supplied by recurrent laryngeal nerve except, and then that exception is cricothyroid, which is supplied by, yes, anyone, what is the nerve supply of cricothyroid? This is external laryngeal nerve, right? So there are 2 points which you should remember for cricothyroid. Number one, it is that it is a tensor of vocal cord, and number two, it is supplied by external laryngeal nerve, and it is an exception because all other muscles, they are supplied by the recurrent laryngeal nerve, right? So just remember 2 things for cricothyroid. Now Broca's area, okay, Sneha, you are absolutely right for Wernicke's, but for Broca's you need slight correction. And if we talk about Broca's area is inferior frontal, right? And yes, of course, for your Wernicke's, it is superior temporal, right? So this is Wernicke's area, right? So this is Wernicke's area, and this is the Broca's area, which is the inferior frontal, right? So this is inferior frontal, right? And this is superior temporal. Clear? Gyrus. This is also gyrus. Now I think most of you must be knowing that this is the motor speech area, and this is the sensory speech area, right? No problems there. As a human, we can just mix up at times. But the priority is that, but the things that whatever you are whatever mistakes you are committing right now, I'm very sure that you won't repeat it again. That's what's very important for the time being, right? So this is Broca's area, and this is Wernicke's area. And any disorder of the language is known as aphasia, right? So aphasia can be motor aphasia, it can be sensory aphasia. In motor aphasia, there is affection of Broca's area. In sensory aphasia, there is involvement of the Wernicke's area. Now, very good, very good. So arcuate fasciculus connecting both, yes. So I can draw the arcuate fasciculus. This is the arcuate fasciculus, yes. So connecting the two, or known as the connecting fibers, right? So here the patient will speak in relation to the question, but the speech will be non-fluent, right? And in sensory aphasia, patient will speak fluently, but answer is not related to the question asked, right? Because there is impaired comprehension. Patient does not understand what actually is being asked. But in motor aphasia, patient do understand, but yes, Raja Charan, they are communicating, right? So they are communicating fibers, yes, right? So, and if there is involvement of arcuate fibers, that is known as conduction aphasia, right? So that is different entity. So motor aphasia, patient can understand the question, but when he tries to speak, there is poor articulation of muscle, so that the words doesn't come out fluently. In sensory aphasia, patient will not understand at all what the question is being asked, but whatever he will say, that the speech will be fluent, but nowhere related to the question asked, right? So this is in short about the speech areas and clinical applied anatomy, right? Now moving forward to the next question, which is not a derivative of the dorsal mesenteric bud. Any idea? This is actually related to the development of pancreas and pancreatic development. There are two parts. One is the dorsal pancreatic bud, and the second is the ventral pancreatic bud. So Raja, Charan, Sunny, absolutely right, gentlemen, you are absolutely right, because this portion comes from ventral and all these three, they come from dorsal, right? Sneha, absolutely right. Shanivaz, absolutely right. So the uncinate process of the pancreas, it is a derivative of ventral pancreatic duct. And if we look here, this is the dorsal pancreatic duct, right? So this is dorsal pancreatic duct, and this is the ventral pancreatic duct. Okay, so this is the ventral pancreatic duct, and you can see here the neck, body, tail, it is all coming from the dorsal pancreatic duct, right? Whereas the uncinate process, this is the uncinate process, it is developing from the ventral pancreatic duct. Clear? So because if you look at the anatomy of the right, so head, neck, body, tail, and this is the uncinate process, right? So you can just divide it like this. So this all area is the derivative of the dorsal pancreatic bud. So this is the dorsal pancreatic bud, right? And this one is the, right, this is the uncinate process, which is ventral pancreatic bud. Okay, so right, and this is the simpler way to remember. Okay, so ventral and dorsal. Ventral will give uncinate process, dorsal will give a remaining portion of the pancreas, right? So this is in short. Now about next question is about umbilical cord. Now can anyone tell me which one of the following statement is true for umbilical cord? Yes, anyone who can tell me which statement is true for the umbilical cord? Yes, anyone? Look at the options. Umbilical cord initially has two arteries, right, and two veins. Okay, so right, left, right, left. Okay, Sneh, Raja, I'll explain this. You both are partially true, but not in true sense. Let me explain this. So what happens? There are two arteries and two veins. But what happens during the course of the time? Right vein disappears and left vein is left. Okay, so there are initially two arteries, two veins, but the right vein disappears and the left vein is left. So that is very important. So left vein is left. Okay, so therefore what you will say, that there are two arteries and one vein, right? So this option is incorrect because it says two vein and one artery. This is not the case. In fact, there are two arteries and one vein, that is left umbilical vein. That's clear? So this option A, the numericals are okay, 2 and 1, but the structures are wrongly mentioned. It should be two arteries and one vein, then it would have been right, right? This is one thing. Now coming to option B, umbilical artery takes blood to fetal circulation. Is it right or it is wrong? No problem, Sneh. Is it, no, option B, is it right or wrong? Now this is again very interesting, and let me see first, and then I'll give you the concept, and hopefully you will never forget in your life. About option B, Shahnawaz do agree that option B is right. Now I just want to ask from some other attendees whether you feel that option B is right or wrong. You can just answer right or wrong, true or false, whatever, and I'll understand your views. Yes, I'm waiting for your response. Umbilical artery takes blood to fetal circulation. Is this Raja, Charan, Sunny? Yes, you are absolutely right. This statement is also wrong. Now let me tell you the concept. See, Sneh, Pranav, let me clarify. See, usually when we talk about arteries, we usually say that these are the vessels which take the blood away from the heart. But that is not the true case, because there are two arteries which actually takes the blood towards the heart, right? So one is of course the umbilical vein, and the second is pulmonary vein. So there are two veins which takes the blood away towards the heart, and these are the umbilical vein and pulmonary vein, right? So they bring the they bring the oxygenated blood, right? So they are carrying the oxygenated blood. And usually what we say, that veins they are carrying the deoxygenated blood. That is what we usually discuss, right? So when we say veins, they carry deoxygenated blood, right? So but there are two exceptions. There are two veins which are carrying the oxygenated blood. One is umbilical vein and second is pulmonary vein. Okay, so umbilical vein and pulmonary vein, they are carrying oxygenated blood, number one. Number two, the blood which is coming from the mother to the fetus is oxygenated, right? And when I am saying that it is oxygenated blood, so it is coming from umbilical vein from the mother and it is going to the fetus. So here the answer should be umbilical vein, right? Then this option would have been correct. Okay, so umbilical artery carries deoxygenated blood from fetus to mother, and umbilical vein carries oxygenated blood from mother to fetus, right? Because whenever we discuss about veins, we feel that they carry deoxygenated blood. So it is not the case all the times, especially in two arteries, especially in two veins, umbilical vein and pulmonary veins, these are carrying oxygenated blood, right? So this artery carrying oxygenated blood, this is actually oxygenated, this is about oxygenated blood, right, which is going from mother to fetus. So it is not the artery which is carrying oxygenated blood, it is actually the vein which carries the oxygenated blood, right? So this option is also wrong. Now coming to the third option, Shanawaz bhai, this is I think 2019 NEET-PG, right? So I haven't labeled the years as such, but I think this is either 2018 or 2019, right? So 18 or 19, but NEET-PG of course. What about option C? What about option C? Is it? Yes, Raja Charan Sani. This is the right answer, because when we see the cross section of the umbilical cord, we will see that there is Wharton's jelly, right? So this is the Wharton's jelly, okay? And this in this you will find two arteries. This is one artery, this is second artery, and you will find a single vein. Okay, so this is the single vein here. Okay, so I think now you will never forget that there are two arteries and one vein. Clear? And the matrix is of course the Wharton's jelly, right? So option C is correct. Okay, so just remember, umbilical vein carries oxygenated blood from mother to fetus, and there are two arteries and one vein. Now, so what we came to know, that there are two umbilical arteries, right? This is one thing, and there is left umbilical vein, right? So this is what we have derived from this discussion. Now these are fetal structures, okay? These are fetal structures, and we know that once the fetus is born, the physiology changes, and these fetal structures, they disappear in the infant life. And can anyone tell me what are the remnants of these structures? So yes, anyone? What is the remnant of the two umbilical arteries? What is the remnant of the left umbilical vein? The two umbilical arteries persist as, again this is a very common snare, not allantoin. This is medial umbilical arteries, right? So again the important point is medial. Urachus, it persists as median, right? So that is also, and yes, I do agree that is slight confusing. Urachus, it persists as median umbilical ligament, right? Yes, I'm sorry here, this is ligament actually, so this should be ligament. Okay, so this is ligament. Fine. So the only difference is here it is N and here it is L. Pranav, yes, you are absolutely right. The urachus, it persists as median umbilical ligament, and the two umbilical arteries, they persist as the medial umbilical ligament, right? So it's only just one alphabet which differs between the two entities. So I'm very sure now you will make sure that you won't mix up in this concept anymore, right? So, and for what about the derivative, or what about the remnant of the left umbilical vein? Left umbilical vein, it also persists as a ligament, and that ligament is known as yes, anyone? Left umbilical vein. Yes, Sneha, you are right. This is ligamentum teres. Yes, absolutely right, Sneha. Yes, perfect. So I think these are few points which you should remember. And since we are already discussing the remnant, so there are two more structures, the remnant of which you should remember. One is ductus arteriosus and another is ductus venosus. So now these are quite easy to remember. What you need to do, you need to add the word ligamentum first. Okay, so I think most of you can answer this. So ligamentum has to be the initial word, and here you will use the word arteriosus, and here you will use the word venosus, right? So ductus venosus will persist as ligamentum venosum, and the ductus arteriosus will persist as the ligamentum arteriosum, right? So these are the important 5 adult remnant of fetal structures which everyone has to remember by heart, and I think most of you must be knowing all this. It's just a matter of time whether it clicks to you or not. And Sneha, yes, you are absolutely right. The ductus arteriosus is derived from the 6th aortic arch artery, but Sneha, you have to be very specific whether this is right or left. You have to be very specific whether this is right or left, because it is only on one side, not on both the sides. So this is right or left? No, Sneha, it is not right. Anyway, not a problem. Let me clear you. This is left. Okay, so this is left. And Pranav, okay, let me clarify, and maybe if you get the concept, I am very sure you won't mark it wrong next time. Now, to understand whether it is right or left, let me give you a concept. Suppose this is say the arch of aorta, right? And then we have the pulmonary trunk, something like this, okay, divided into the left pulmonary artery and the right pulmonary artery, okay. So now the arch of aorta is on which side, left side or right side? The arch of aorta and then descending aorta, it is on right side of the body or left side of the body? So this is left side of the body, okay, this is right side of the body. This is one thing. Now the ductus arteriosus is somewhere like this. This is ductus arteriosus, okay. So this is the ductus arteriosus, and this ductus arteriosus is seen more on the left side. Okay, so ductus arteriosus is more on the left side. Clear? And therefore you can correlate that since the ductus arteriosus is on the left side, so it is a derivative of the left sided sixth aortic arch artery, and to be more specific, this is the distal part. Okay, this is the distal part, and thank you, Sneh. So this is the distal part, because from proximal part of sixth aortic arch artery, we have the development of the pulmonary arteries. So on the right side there is right pulmonary artery, this is right pulmonary artery, and on the left side we have the left pulmonary artery, right? So right aortic arch proximal portion, right side right pulmonary artery, left side left pulmonary artery, and the distal part is forming the ductus arteriosus only on the left side, right? So just remember this, and this is again a very favorite concept, right? So I am very hopeful that you won't forget it, that it's only on the left side, and ductus arteriosus has nothing to do with the right side. It is only an entity of left side, right? And even like I would add something more here, the if you know the anatomy of the left recurrent laryngeal nerve. Now the left recurrent laryngeal nerve actually goes like this. So suppose if this is the vagus nerve, this is the left vagus, right? Then the left recurrent laryngeal nerve passes below the ductus arteriosus, right? So this is left recurrent laryngeal nerve, right? And therefore this left side recurrent laryngeal nerve is longer because it is going lot towards the lower side just to wind round the ductus arteriosus. And yes, in an infant or a newborn, we don't find ductus arteriosus, it is ligamentum arteriosum, right? So the concept is that it passes behind the ductus arteriosus, and therefore the left recurrent laryngeal nerve is comparatively longer as compared to the right recurrent laryngeal nerve. So anyway, this is all embryological concept. Okay, coming back to the paper once again, right? So the next question is about uterosacral ligament. Now, as the name suggests, utero is uterus, sacral is sacrum. So I think all of you can answer that what is the location of this ligament, and it is supporting the uterus on which part. Yes, wonderful, wonderful. So this is again, if you look here, this is the uterus here, okay, especially the cervix of the uterus, and this is the uterosacral ligament going behind till the sacrum, right? So you can clearly see that it is supporting on the posterior aspect. And in terms of the structures which are stabilizing the uterus or which are supporting the uterus, you can see a transverse cervical ligament, which is also known as the McEnroth's ligament, right? So this is very important here. So this one is the main structure which actually supports the uterus. So transverse cervical, and sometimes it is also known as McEnroth's ligament. Yes, Pranav, you are absolutely right. This is posterior. And anteriorly we have one ligament which is extending from the cervix to the pubic symphysis, that is pubocervical. So pubocervical is anterior, uterosacral is posterior, and transverse cervical is lateral. So this is lateral going up to the pelvic walls. So this is just in short about the supports of uterus. Now, last fontanelle to ossify or fuse in a child. Yes, Sneh, muscle wise levator ani is very important. Yes, of course, related to pelvic floor. Yes, next question, last fontanelle to fuse in a child. Any idea? last fontanelle. Now we know that fontanelles are actually spaces at the junction of skull bones. See, the important fontanelles which you have to remember are only two: anterior and posterior, right? Posterior fuses somewhere between the age of 3 to 6 months, and the anterior fuses around 12 to 24 months. Clear? So just two: posterolateral, anterolateral, they are not significant enough, and the answer therefore would come out to be the anterior fontanelle, right? Yes, Rajacharan Sani, you are absolutely right. Some books says 16 to 24, some says 18 to 24, even 12 to 24, that is all accepted. But yes, the maximum time limit is 2 years. So we know that these fontanelles are actually the spaces at the junction of the skull bones. And what is the importance? They helps in molding of fetal skull during delivery. Clear? So there is some amount of overlap, or there is some amount of molding, and this helps in passage of the fetal head through the maternal genital tract during the normal vaginal delivery, right? And with time these ossifies and we don't find the gap as such. So for anterior fontanelle, just remember 12 to 24, and posterior fuses by somewhat by 6 months. So just these two are important to understand, right? Chalo, next question is a very beautiful concept, and that is related to phrase syndrome. Phrase syndrome. Any idea what is this phrase syndrome? Very good, Sneh. You are absolutely right. This is auriculotemporal nerve, and auriculotemporal nerve is coming from trigeminal nerve. Yes, so this is about auriculotemporal nerve. Perfect. Right? Yes, Sneh, you are absolutely right. Now, what is phrase syndrome actually? Now, usually what happens when we eat food, there is salivary secretions from the parotid gland. But what happens, the nerve fibers, they after injury, they rather than they connecting to the parotid, they connect to the sweat glands. So what happens when the patient is eating something, and instead of salivary secretion there starts sweating. So this is known as gustatory sweating. So gustatory is related to eating food. You can say chewing or eating food. So rather than salivary secretion, there occurs sweating. So that is gustatory sweating, and that is a case of faulty regeneration. So suppose these are sweat glands. Okay. Now sweat glands are having sympathetic innervation. So this is sympathetic innervation. Clear? And the parotid gland, it is having parasympathetic innervation. So this is parasympathetic innervation, and of course coming through the auriculotemporal nerve. So what happens, suppose if there is injury somewhere here, right? So suppose if there is injury somewhere here, so whenever there is regeneration, so ideally it should connect in the same manner. But what happens, rather than connecting in the same direction, it goes and it connects somewhere here. So what happens, the parasympathetic are taking the command for secretion, But since it is not going to parotid, it is going to sweat glands. So there will be secretion from the sweat gland, and that is actually sweat, right? So whenever there is food eating, instead of parotid gland saliva secretion, there is secretion of sweat. So that is known as gustatory sweating. So lingual nerve takes general sensation from anterior two-third of tongue, right? So lingual nerve is different. It takes general sensations from anterior two-third of tongue. Okay. So here, this is because of faulty regeneration, and instead of the regeneration which should have gone to the parotid gland, now it has reached up to the sweat glands. And as the command is coming for secretion, and it is going to sweat glands, so sweat glands are secreting the sweat. So that's why patient is eating food, but instead of saliva secretion, there is sweating, and that is known as gustatory sweating. So this is a very beautiful concept of phrase syndrome, and you can see here, this is the auriculotemporal nerve, right? And this is the sympathetic command which is going to the skin, supplying the sweat glands and also the blood vessels where it causes vasoconstriction. But we are more interested in discussing the sweat glands. And then there is the parasympathetic part which is going to the parotid gland, and it results in saliva secretion. So once this part is injured somewhere here, so in the regeneration process, rather than going to the parotid gland, it is going towards the sweat gland, right? So this is actually going towards the sweat gland. So therefore we call it faulty regeneration. Rather than going to the sweat and to the parotid gland, it is going to the sweat gland, and since it is carrying the signal of secretion, so if would have been gone to the parotid, it would have led to saliva secretion. But now since it is going to the sweat gland, so it will secrete sweat, and therefore patient will develop sweating whenever there is eating of food, right? So this is gustatory sweating, and a beautiful concept of phrase syndrome because of faulty regeneration of the auriculotemporal nerve, which is a branch of the trigeminal nerve, right, or cranial nerve 5, right? So this is phrase syndrome. Now I have just kept one more question on the phrase syndrome, and let me strengthen your concept of the phrase syndrome. So let me see whether you can answer this or not. And now here you have to answer in accept. So you have to tell me what option is wrong here. And let me correct, this should be gustatory sweating, right? This should be gustatory sweating. So what about option A? Is it correct or is it wrong? Tell me. Option A, is it correct or is it wrong? Yes, I am waiting for your responses. Just write T for true, F for false. I'll understand your answer. Yes, perfect, perfect. So this is a true statement for, yes, Raja, Shanawaz, all of you are correct. Wonderful. So, okay, one thing is clear, that phrase syndrome is gustatory sweating. Now, what about option number 2? T oblique F. T for true, F for false. What about option B? Whether it is true or is it false? Sneha Rathod, yes, this is true. Because there is, yes, Shanawaz, it is true. Raja Charan Sani, it is true. Yes, because there is abnormal re-innervation, right? So the word is re-innervation, and rather than, because there are two structures, one is sweat glands and another is parotid gland, right? So the regeneration or re-innervation should have been here, but this is not the case. The re-innervation has misdirected. So abnormal re-innervation, that is true. Now what what about option C? What about option C? T oblique F. Yeah, I think this will be a little. I think this will be a little tough for you. Yes, we can minimize the chances of phrase syndrome by doing extracapsular dissection, right? So this is also true actually, but yes, I think it will be little difficult for you. So extracapsular dissection decreases the chances of phrase syndrome. That is a true statement. So now we are left with the false statement, and that is the faulty connection between the 7th and the 5th nerve. Now, can you tell me what is wrong here? Why this statement is wrong? Because in discussion of the phrase syndrome, there is never any mention of facial nerve. It is only the 5th nerve, auriculotemporal branch, which rather than going to the parotid is actually going to the sweat glands. Okay, so there is no concept of any faulty connection or any involvement of facial nerve actually, right? So this is the case of phrase syndrome, right? So I think this is clear to all of you now. Okay, so again, if we can see here, this is the auriculotemporal nerve, and then there are two fibers, the sympathetic fibers, which are importantly in discussion part, which are going to the sweat glands, and they promote secretion of sweat, and the other fibers are the parasympathetic glands, which actually go to the parotid and lead to secretion of saliva. Now what happens when there is injury to this parasympathetic part, and when there is process of regeneration or reinnervation, rather than the fibers going to the parotid, right? So rather than going to the parotid, they deviate towards the sweat glands, and when they deviate towards the sweat glands, what they will do? They will lead to sweating whenever the person is eating food. So that is phrase syndrome, and that is because of involvement of the auriculotemporal nerve. Fine. So this is the beautiful concept of phrase syndrome, and I am very sure that if there is any question, you can at least apply this concept to reach up to the correct answer, right? So this is phrase syndrome. Now moving forward, and there is one muscle which is being shown, and let me see if you can answer the nerve supply of this muscle shown in the figure, right? So if I draw this muscle, so this is the muscle here. So yes, can anyone tell me what is the nerve supply of this muscle? And again, before answering or before marking the nerve supply, you have to tell me which muscle is this actually. Which is this muscle? Tell me the name of the muscle. Yes, everyone's answer is absolutely correct, but let me know whether you know the name of the muscle or properly or not. Okay, let me clarify first. This is thumb, right? This is index finger, right? Number one. Number two, any muscle which is related to thumb should have the word pollicis in between, right? So any muscle, extensor pollicis longus, extensor pollicis brevis, abductor pollicis, whatever. So if any muscle is inserting over the thumb or resulting in the movement of the thumb, it should have the word pollicis here. Now this muscle, whatever I am trying to show you, it is onto the index finger only. So one thing is very sure, we will not use the word pollicis here, right? So that is one thing. Now what important clue is there in this question, and let me show you. If you see here, there is a long tendon going like this, okay? And this muscle is actually originating from this tendon, right? And this is one tendon which is of a muscle which is having 4 slips, right? So this is, if you look here, This is a tendon which is having 4 slips, and if we look here, it is having 2 parts, right? So it has got a medial half and it has got a lateral half. So can you think of any muscle which is having 2 halves, lateral half and medial half? Lateral half is supplied by median nerve, and then medial half is supplied by ulnar nerve. So this muscle is actually the flexor digitorum profundus, right? Number 1. Now, the very first question was about the same thing. From the tendon of the flexor digitorum profundus, there is origin of the lumbricals, right? So the lumbricals, they originate from the tendon of I'm extremely sorry. So this is lumbrical, right? So this is clear. Yes, Rajacharan, Sunny, you are absolutely right, and I think Sneha, you also have got the point now. So what this muscle is actually lumbrical, right? This is one thing. Now I told you before that lumbrical 1 and 2, they have different nerve supply, and 3 and 4, they have different nerve supply. So 1 and 2 is supplied by median nerve, and 3rd and 4th is supplied by ulnar nerve. And then last thing, the counting has to be done from lateral, right? So how you will say that the given lumbrical is 1st or 4th? We know that counting has to be like this, lateral to medial, because this is lateral, this is medial. So this will come out to be the 1st lumbrical, right? So what is this? This is 1st lumbrical, and for 1st lumbrical, you know that the nerve supply is median nerve. So that is how you have to correlate the concept. Even if you don't know the image, if you know this concept, I am very sure you will get your answer, right? So this is the reason why we are choosing median nerve here and not ulnar nerve, because ulnar nerve is for 3/4. So for ulnar nerve, these are the medial 3rd and 4th tendons. So whatever the lumbricals are originating from these portions, like these one, they will be supplied by the ulnar nerve, right? So 1st and 2nd by, so this is of course the 1st and this is the 2nd. So 1st and 2nd by median nerve, 3rd and 4th by ulnar nerve, right? So I think this concept is clear now. So this is how you can remember. Now this is again one very important question, because whenever we discuss the cutaneous sensor vision of the hand, we usually discuss the palmar aspect or the volar aspect, 3.5 for median nerve and the medial 1.5 for the ulnar nerve. Now this question is about the dorsal aspect. So this is the dorsal aspect of hand. So this is the dorsal aspect of the hand. Now tell me, which nerve is this? Which nerve is this? Sneha, okay, AIN palsy, okay. I'll just take some break and let me clear Sneha's doubt first. So, anterior interosseous nerve, right? So this is just Sneha is asking for that. Now, firstly, you need to know what is this anterior interosseous nerve. It is a branch of median nerve, right? Number 1. Then number 2, since we are discussing anterior interosseous nerve, so we should know what is posterior interosseous nerve. And at many places we usually discuss, like, if there are branches, anterior and posterior are from the same structure, but this is not the case here. Anterior is from median nerve, posterior is from radial nerve, right? So this is the radial nerve. Okay, this is one thing. Now the radial nerve, especially the PIN, it is resulting in extension of the metacarpophalangeal joint, right? So what is the role of PIN? Extension of MCP joint. And now here we discussed that flexion at MCP joint is caused by lumbricals, right? So flexion at MCP joint, this is lumbricals, right? So one thing is clear: flexion MCP, lumbrical; extension MCP, posterior interosseous nerve. Now this is an interrelated concept, so I'm taking everything, right? So I'm not restricting myself to AIN, I'm just taking the PIN also, because actually we are discussing the interosseous nerves, right? Okay, so if there is paralysis, this will result in clawing. Clear? This we have already discussed, something like this. If there is paralysis here, this will result in finger drop. Please mind that is not wrist drop. So finger drop means finger will be like this, and this is because the extensors are paralyzed, so the lumbricals become overactive and they keep the MCP in this attitude. So finger drop, they cannot be extended like this. So this is finger drop. Okay, so this is lumbricals clawing, and I think lumbricals, when we say, we mean both the nerves here, median and ulnar, right? This is one thing. PIN is okay. Now coming back to anterior interosseous nerve, which is a branch of median nerve, and now which muscles it supplies? It supplies three muscles. All the muscles of the, if we take the group, deep flexor compartment, right? Because we know that there are two compartments in the flexor part of forearm: superficial having 5 muscles and deep having 3 muscles. So all the 3 muscles are supplied by anterior interosseous nerve, which is a branch of median nerve. Now what are these 3 muscles? One is pronator quadratus. Don't mix it up with pronator teres. This is pronator quadratus, right? Somewhere here. So this is pronator quadratus. Okay. Number 2 is flexor pollicis longus, the long muscle which is going to the thumb. And third is flexor digitorum profundus. So whatever the discussion we have done in terms of lumbricals is actually more specifically the anterior interosseous nerve, right? So this median is actually more specifically, this is anterior interosseous nerve. Got my point? So this is actually the lumbricals also here, originating from the tendons of FDP, right? So, and we know that FDP they insert onto the tip into the distal phalanx. So this flexion is brought about by FDP. Okay, so that is very important. So anterior interosseous nerve is a branch of median nerve actually. So many times, rather than specifically mentioning anterior interosseous nerve, we talk about median nerve. Okay, so this is very important in terms of AIN. And yes, for discussion part, we never go that specific like AIN. We always take the parent nerve, that is the median nerve, right? So that is in short about AIN. Okay, so Sneha, I hope that might have satisfied you to an extent, right? Okay, so moving forward to the next question, and again we are discussing the dorsal aspect, this part. Thank you, Sneh, thank you. So we are discussing the cutaneous distribution of this part, and before we proceed on to this, just let us recap, just have a recap of the volar aspect. So suppose if these are the fingers like this, so again we know the concept of 3.5, right? So this is all territory of median nerve, right? So this is all median nerve, and of course the remaining part is all territory of the this is all ulnar nerve, right, in terms of cutaneous innervation, right? Now when we look at the dorsum, we are getting 3 nerves in consideration, right? Here on the volar side there is no area related to any point where radial nerve is giving cutaneous innervation. Now in the dorsal aspect we have to consider radial nerve as well. Now here very easy is for you to identify the yellow area, which is ulnar nerve, right? So here also it is almost 1.5, right? Here it is 1.5. So volar, dorsal 1.5. I think ulnar nerve is quite easy. Now when we talk about the lateral 3.5 dorsum part, here it is not the entire area, is not the territory of median nerve. Median nerve is limited only upwards, right? So orange part is median nerve, and lower down this is all radial nerve, right? So in simpler terms, dorsum of first web space, second web space, like that is all radial nerve. So if someone asks you what is this territory, this is all radial nerve, and this orange is all median nerve, right? So the answer to this question will come out to be option D. Very good. So this is radial nerve, orange is median nerve, yellow is ulnar nerve, and 1.5 same, right? So this is how you can remember it. So radial nerve is giving sensory innervation only on the dorsum of hand, and I'm again repeating, not on the volar aspect of the hand. Chalo. I'm sorry. Now dermatomal supply of this area. Now here you can see this is umbilicus. So here you can see this is umbilicus, and yes, I think for umbilicus everyone can answer what is the dermatomal supply for umbilical region. Mohammed Shanawaz, yes, you are perfect, man. This is area of T10, right? So this is all T10. Okay. Raja Charan, yes, number 1, you are also right. So I think this is quite easy. T10 umbilicus, right? So if you can just memorize the entire thing, it's pretty fine. But if you can't, at least take the important ones. And of course, if this is the umbilicus, okay, and this all territory is T10, fine. So at least do remember this one. This is all T10 in the umbilicus or periumbilical area. Okay, chalo. Now in urinary bladder there is a prominence that is known as uvula vesicae. Now whenever you find the word vesicae, this is actually urinary bladder. Okay, so this is urinary bladder. So there is a prominence in the urinary bladder, which is because of one lobe of prostate, and that is actually the median lobe. Okay, so this is actually the median lobe, and if we see the section here, we can see this is the prominence in the prominence within the urinary bladder, and this prominence is known as the uvula vesicae, which is an impression created by the median lobe of the prostate gland, right? So this is because of the median lobe of the prostate gland. Now look at the image, and it is showing a foramen here. So there is a foramen here. Now it is being asked that which nerve passes through this foramen. So firstly you have to identify the foramen. So which foramen is this, and then only you can tell about the nerve which passes through this. Yes, this, which foramen is this? This is actually mandibular foramen, right? So this is mandibular foramen, and through mandibular foramen there is passage of inferior alveolar nerve, right? So the answer here will be inferior alveolar nerve. Yes, Rajacharan Sunny, you are absolutely right. Shanawaz, you are absolutely right that this is mandibular foramen, and see, this is mandibular foramen, but the nerve which is passing through this is the inferior alveolar nerve. Okay, and again inferior alveolar nerve is a branch of trigeminal nerve. Okay, so this is inferior alveolar nerve. So if you see, this is visible from the inner part. So this is all the mandibular foramen. Okay, chalo. And now this is very important section, and almost every year we have a question either on the sagittal section or transverse section, coronal section, whatever. So, and it is like you have to identify some marked structure. Now in this particular case, you have to identify the structure which has been colored with red, and I think it is quite easy to identify. Let me see if you can identify that or not. So the structure which is marked in red is yes, anyone? What is this structure which is marked in red? Yes, Raja Charan, number 1, Shanavas, yes, all of you are correct. This is cerebellum, right? So this is cerebellum, yes. This is cerebrum, okay. And then this is the corpus callosum, okay. And then here you can see the cavity, that is the lateral ventricle, okay. So that is lateral ventricle. Then lower down, this is midbrain, right? And then this is pons, this is pons here, and lower down the pons we have the medulla, which continue down as the spinal cord. Okay, so this is the structure in this sagittal section. Okay, yes, so everyone, this is cerebellum. So this is all brain stem, and in brain stem we know that there are 3 parts. Upper part is midbrain, then pons and medulla. And now this is all pons here. Okay, so this is all pons, right? So this is all pons here, and posterior to the pons you can see this shape. Now what is this? This is the 4th ventricle. Clear? So because pons forms the anterior boundary of the 4th ventricle, so this diamond shaped structure is the 4th ventricle, which is between the cerebellum and the pons, right? So this is cerebellum, and I think everyone can identify this. So just a different diagram to just clear your concept. This is of course cerebrum, right? This area is all corpus callosum. Okay, so this is a corpus callosum, which is actually a communication between the 2 cerebral hemispheres, and they are meant for coordination, right? So both the cerebral hemispheres should know what is going in them, right? And this is the lateral ventricle here, one in each cerebral hemisphere. Then this is of course cerebellum, right? Here you can see this is the 4th ventricle, right? So this is the 4th ventricle. Then in the green is the midbrain. Below the green in orange is the pons, and in aqua is medulla, and in purple is spinal cord, right? And then here we have the thalamus and hypothalamus, which is known as the diencephalon, right? So this is in short about the sagittal section. So this is the sagittal section, right? So please be perfect with the structures, neural structures. Now next question was about the muscle which is derived from the first pharyngeal arch. the muscle which is derived from the first pharyngeal arch, and it is anterior belly of digastric. Remember, posterior belly of digastric is from second pharyngeal arch, stylopharyngeus is from third pharyngeal arch, and this is fourth to sixth pharyngeal arch, right? Now, as the nerve supplies, this is again the mandibular nerve, this is facial nerve, this is cranial nerve 9th, and this is the recurrent laryngeal nerve, right? So in short, the muscles of the anterior belly of digastric, this is the first pharyngeal arch, okay, so supplied by the trigeminal nerve through the mandibular division or maxillary. Then the posterior belly of digastric, this is second, supplied by facial, and then the levator veli palatini is 4 to 6, supplied by vagus, right? So just in short, please be perfect with this part, because in one or other way it is always being asked, right? So instead of mandibular, we can write fifth cranial nerve, right? So this is all cranial nerves, okay? Chalo. Now this is again a very basic question. Side to side movement at neck, which joint? Side to side, it's actually the movement of no. So this is actually the movement of no. So if you want to say no to someone, you will just do a nodding movement, and that is side to side movement. And I think most of you might agree that this is actually a movement occurring at the pivot joint, which is C1 C2, right? So this is C1 C2. So again you can see here, this is atlas, this is axis, and this is the dens, which is also known as the odontoid process, okay? So the first cervical vertebra, it just rotates along this dens, okay? So this is the odontoid process or the dens of the second cervical vertebra. So the movement, the rotation movement occurs along that. So this is a pivot joint, atlanto-axial joint, right? So that is enough for this session, and I'm extremely thankful to all of you for waking up so late just to attend this particular session. And so thank you very much, and we will have one more subject tomorrow, 10:30 p.m. Indian Standard Time, and that I'll inform you timely. The link will be shared in the Telegram group as well. So do make sure that you are part of this Telegram group, and you will get the link, and moreover timely notifications about the classes, right? So I hope you must have enjoyed the session, and see you tomorrow, 10:30 p.m. Good night. God bless.